So, good evening and a warm welcome to all the dignitaries present here. I am Shrishti from Clearnet, assigned as the session assistant to ensure a seamless experience. Clearnet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clearnet is the digital partner of this event organized by Indian Association of Preventive and Social Medicine. And the focus for today's session is Outbreak Investigation, a journey in decoding the Nipah mystery. So let us begin today's session, for which I would like to hand over the session to Dr. Animesh Jain. Sir, over to you.
Thank you, Srishti, and thank you, Clearnet. So welcome all the viewers. Good evening and greetings to you from wherever you're watching. We are again here with another session of IAPP webinar. That is, we have started this IAPP, that is Interinstitutional Academic Program for Postgraduates, way back when it was pre-COVID, and it was actually a physical program. But then COVID gave us an opportunity, and we are leveraging the strength of the technology. So we come with all these webinars from time to time, and usually at a monthly frequency. So today we have another edition. And before I go on to the main program and introduce the speaker and hand it over to her, I would like to introduce, I would rather ask and invite Dr. Poonam, the president of our IAPSM Karnataka chapter, to have the welcome address and have opening remarks. So over to you, Dr. Poonam.
Thank you, Dr. Animesh. A very good evening to one and all assembled over here. And firstly, let me also extend the New Year greetings to everyone. So, and we are beginning with, we're starting the new year with a very important topic of academic importance as well as practical importance in the field of public health. And I hope we would be continuing that across the year as well. So, with the globe facing all the emerging and the re-emerging infections, experience of outbreak investigation in any of the state or the country remains very critical for everyone. And I believe Dr. Asma has worked closely with the Kerala government during this particular outbreak investigation. And so this particular experience of her that she would be putting across and how did they tackle it or manage it, I think that would be of great significance for each one of us who has assembled over here. So I thank Dr. Asma on behalf of IAPSM Karnataka State Chapter for having accepting our invite. And I'm sure this would be a really a fruitful learning experience for all. Thank you.
Thank you, Dr. Poonam. And I appreciate the presence of Dr. Asha, Vice President of IAPSM Karnataka chapter. Dr. Sunil, our Secretary of the Association, has not been able to join because he's stuck in the traffic. However, moving forward, I again want to thank Clearnet and IAPSM Karnataka to have this journey continuing for, I think, years now. And I also want to acknowledge Clearnet and Shrishti and also Ritu Safar, who's been instrumental in logistics as well as the preparation of flyer. And so also Dr. Asha for coordinating. Let me take it further. So as we all know that we have a very, very important topic. And though this program is called the academic program for postgraduates, but we actually have topics which are of interest to anybody and everybody at different levels. And today we have Dr. Asma Rahim, who's going to talk about the outbreak investigation, and she will also bring in her expertise and experience that they had during the Nipah outbreak in Kerala. And to introduce Dr. Asma, so Dr. Asma is a professor and head of Department of Community Medicine at the Government Kozhikode Medical College, that is Calicut Medical College in Kerala. And other than that, she has been passionate about medical education. She has been a Famer Fellow of 2011 batch from PhD Coimbatore. She's also done her International Fellowship in Medical Education, IFME, which is a very, very difficult fellowship to get selected into, but then she has pursued that. She's very keenly interested in lots of medical education areas, but one of the passionate things that she pursues is communication skills, which she's been instrumental in coming out with a program in her institute regarding the communication of interns and later extrapolated to medical students. I work closely with her. We also are facilitators of FAMER on-site programs, and Dr. Asma is one of the core members of the PME team, as we call it, that is Program Management and Evaluation team. And she is a very good teacher. She's been an author of a textbook, which is The Principles and Practice of Community Medicine by J.P. Brothers. And she contributes a lot to the literature in form of different publications and research and other means. So with that short introduction, Dr. Asma, welcome to this forum. Thank you for obliging us. It's been long due, and it's all over to you. Thank you.
Thank you, Animesh, for that introduction, which is which has boosted my what is that energy, which is low at this point of time. Anyway, thank you. So it's a
Another thing I
pleasure
want to mention
to
that
be
you have
here,
just
and
finished,
thank you.
Asma, you have just finished the CISP workshop yesterday and today in your center, right?
Yeah.
So so thank you for
Today,
obliging. Yeah, that's
yes,
what, yesterday
I've
and today.
finished.
That's what I said, yesterday and today.
Yes. Yeah, that's why I said that I'll be free by today to today evening. Okay, so pleasure to meet you all and be with you. And thank you for that introduction. Thank you, Dr. Poonam and Dr. Asha for being here. So with that, let me start shall I start my presentation?
Yes, please. Go ahead.
I think
Yeah, it's seen.
it's
You
the
just
same
have to,
thing,
yeah.
I suppose,
No, you
yes.
have to just make it into a full screen, that is slideshow mode.
Is that fine?
Yes,
Am I
yes.
audible?
Yes, you are audible. The slides are visible. It's all
Okay,
fine. Please go ahead.
right. So today, I think there are a group of postgraduates, I presume, in community medicine, listening to my presentation. Is that so, Animesh?
There are some postgraduates, there may be a few faculty members, so it's
Oh,
open to
yes.
everybody. It's open to
Okay,
everybody.
okay. So I'm glad to be here to share our lived-in experiences on outbreak investigations in the recurrent Nipah outbreaks in my state of Kerala. So fortunately or unfortunately, from a public health point of view, I had the opportunity to be a part of the investigation team in the first outbreak which hit us in 2018, and then we have had recurrent outbreaks in the years 2021 and 23 and 24. So again, I was part of the epidemiological link and contact tracing team in 2021 and 23 outbreaks. So with whatever learnings I've had, I would like to share with you regarding this deadly lethal disease. So at that outset, why is it important to public health personnel? The recent publication by the World Health Organization, let me show the pointer option. Yes. So there's a recent publication document by WHO. That is a regional strategy for prevention and control of Nipah virus infection. So following the 2018 outbreak in Kerala, WHO has accorded a Nipah virus into the category of high priority pathogens posing regional threat. And that is why they brought out a document for that purpose. And it is a document worth reading. So the focus of today's presentation is on understanding the epidemiology of Nipah outbreak and then taking you through the events that have occurred in Kerala, thereby gaining some knowledge and be job ready as public health professionals to respond and in prevention of Nipah outbreak. So I'll be taking you through all these aspects of the outbreak investigation, which we have been a part of. So let us take a look at the time trends of Nipah outbreaks over this period, 1998 to 2024. So if you look at this, till 2019, almost 20 outbreaks have been documented, with the first outbreak having occurred globally in Malaysia in 1998. And then there's been a series of outbreaks. And this is not the end, because we have had in India, the first outbreak occurred in Siliguri in 2001, Nadia in West Bengal in 2007. And then after a gap of, let's say, 11 years, the virus struck Kerala with recurrent outbreaks in 18, 19, 21, 23, and 24. And the case fatality rate in the 2018 outbreak was really, really staggering. So that's something which is important. Now, if you look at Bangladesh, which is our neighbor, we are fortunate that uh, outbreaks do not occur every year as it does in Bangladesh, but things can change here too. If you look at you can understand that. So every other year, Bangladesh has cases with almost high case fatality rates due to Nipah, case fatality rates ranging from 25% to 92%. So that's the global scenario. Now, why are we so concerned about Nipah? Because it is a highly fatal disease to the victims. So what is happening to the case fatality rate? So if you look at the number of cases, what is striking here is in the initial epidemic in Malaysia, the case fatality rate was moderate, around 38%. And even Siliguri, Nadia, 5 cases were there in a family and all the 5 died. But let's look at the first outbreak in 2018 in Kozhikode and Malappuram, which is with a high case fatality rate. And you can also appreciate how the case fatality has gone down and how we have been able to limit the number of cases and how we are able to achieve that. So that will be the crux of this presentation. So recurrent outbreaks is the theme in Kerala right now. Sorry. And if you look at the agent, it is a highly virulent paramyxovirus. It is a cousin of the Hendra virus in the family of Nipah. Note that highly infectious virus with high case fatality rate and biosafety level 4 pathogen, which is concerning. The biosafety, the pathogenicity is really concerning. So look at this. What makes this virus so aggressive? So undoubtedly, the structural characters of the virus. So we can appreciate that it is an enveloped virus and a single-stranded RNA virus with viral nucleoprotein consisting of nucleocapsid, phosphoprotein, and long polymerase. Similar to COVID virus, it has glycoprotein spikes, which helps it to latch onto the mucosal surfaces of the host, and a fusion protein, which helps in cell entry and multiplication. What is concerning is it has got 6 structural proteins and there could be mutation in each one of them. So that's concerning. So the mutations over a long period of time, it can change. And therefore, that's something which we need to keep in mind. You might wonder whether a single strain of the virus is causing the disease, or are the strains different in Bangladesh, Malaysia, and India? Now, NIV genomes have been studied extensively from humans and animals from Malaysia, Bangladesh, and India. And, and the experts have found out that 2 clades are there. Clade 1 is the Bangladesh and Indian strain, and clade 2 is a Malaysian strain. Also from Kerala, studies of the recurrent recent outbreaks have identified another clade which is close to clade 1. So these strains have more than 92% similarity in nucleotide homology. Now, coming to the host factors, which are the hosts for this deadly disease? Natural reservoir is bats. So they are asymptomatic, that is there. So you cannot just look out for dead and draw bats and say and predict that Nipah is going to occur. Bats don't die. That's the thing. But and then comes the intermediate hosts. They are the pigs, and in Philippines and other countries and in Australia, horses have also been documented as the intermediate host. In Malaysia, the intermediate hosts were predominantly pigs. In India, something which we have not investigated, or we are in the process of investigation now, is there are other domestic intermediate hosts like dogs and cats and even cows, which can act as the intermediate host. So that's important from a public health preventive control angle. And if you look at humans are actually incidental or accidental hosts. And infected pigs, it exhibits a characteristic barking cough. And another point to note is that infected pigs do not always die, but it's the piglets which die than the adult pigs. So these are some of the observations from the host factors. Now, let's talk about the bats. The bats, we may be interested in, because there are a lot of bats roaming around, flying around, and therefore there are a number of species of bats implicated in transmitting Nipah. And the major bat is a flying fox, which is a common bat which we see around, which is a fruit-eating, nocturnal, feeds on ripe fruits like guavas, bananas, mangoes, and even all those exotic trees, fruits which are there. Formerly, it was known as Pteropus giganticus. In Maharashtra, they also were able to do a sero survey and find out antibodies to Nipah in the small bat called as Rosetus leschanolti. So there are other species also, but these are the two which are which have caught attention of the investigators. So now moving over to, this is a WHO infographic, which shows the wide distribution of Pteropus bats. So look at this, it is spread across continents and especially Southeast Asia and Australia and even other Southeast Asian countries. Particularly these green markings here are the home range of Pteropus medius fruit bats, which are implicated in NIV transmission. Over to the environmental factors. These pictures will pique your curiosity. Look at the left side. You have a mango orchard or a mango tree. You can see the bats feasting on these mangoes. And then the mangoes have dropped down and the pigs are taking those mangoes which have been eaten by the fruit bats, and pigs get infected and pigs transmit the infection to humans. This is at one side of the spectrum. Look at Bangladesh. In Bangladesh, what happens is bats feast on the raw date palm sap. Okay, so these are the date palm trees, and this is they collect date palm sap for preparing toddy in Bangladesh. So the bats feast on this raw date palm sap. In that process, they urinate and excrete in the raw date palm. So this goes to show, and then man gets infected. Man takes this toddy without boiling, and then he gets infected. Or it may be that the climber may inhale the aerosols of the bats during tree climbing. So it's basically an occupational kind of risk there. So by modifying this risky human behavior, we can actually control the transmission to a certain extent. So what is concerning us is that, see in these pictures, this is the situation in Malaysia. In A, we are able to point out there is an intermediate host there. Okay, pigs are the intermediate host, and humans get infected from pigs. In case of Bangladesh, we know that a vehicle is there, that is a raw date palm sap, and man gets infected. But look at Kerala. In Kerala, we are unable to find out the intermediate host, or we are unable to find out how does the virus enter from bat to humans. And the assumption is that through the fruits. But then we could not prove it conclusively because we have been unable to find out the agent from the fruit. And that's so simple. So it remains inconclusive. Okay, now let's move over to the incubation period and other clinical features of this disease. It is like, if you look at this, the incubation period is 4 to 14 days. It can go long as 45 days. And there could be two types of presentations in humans. It could present as an encephalitis, or it could present predominantly with respiratory symptoms. We have had both kinds of presentation in the different outbreaks. And are there asymptomatic infections? It is thought yes, because in the Malaysian outbreaks, the investigators found out that there were around 1 to 15% of asymptomatic infections. And in India, in the 2023 outbreak, the NIV experts could actually, through sero survey, detect 3 subclinical infections. So maybe that's also possible. Now, what happens? Why does this, why are the bats transmitting the disease, and what are the factors that leads them to transmit the disease? This is a self-explanatory slide, which is animated. Ecological stress makes the virus virulent. And what are the reasons for the ecological stress? Deforestation, climate change, and loss of food sources. And all those factors, loss of habitat, all these makes this bats highly stressful. And when they get stressed out, what happens? There is an increased excretion of the virus through saliva and urine. So the key principle here is not to disturb them in their normal habitat and stress them out and mess up with them. So normally what happens is people cut down trees and try to address the bat problem, and that doesn't work often, and that should not be done. And also environmental factors. A number of environmental factors aids this transmission. Deforestation, undoubtedly. Wildfires. It is thought that in Malaysia, the outbreak happened after an intense wildfire in Indonesia. So, and even the climate change due to El Nino phenomenon is linked to the recurrent outbreaks that have happened in Kerala and right now. Another point is rapid urbanization and encroachment by cutting down the trees at the bat roosting sites, forcing them to look out for alternate habitats, and in turn causing a lot of stress. New agricultural practices like exotic fruit plantations like rambutan, mangosteen, and all these have actually contributed to this disease in Kerala, because bats love these fruits and they tend to roost around these sites. So with that, I'll try decoding the recurrent outbreaks in Kerala and what were the learnings from that outbreak. How did we go about it, especially during the first outbreak in 2018. So I'll share a story. The year was 2018, and on a sultry summer evening in May 17th, a 28-year-old male was wheeled into the casualty of a major private healthcare facility in Kozhikode. He had traveled around 50 kilometers from his hometown, which is called as Changaroth village, to the casualty. And what happened? What happened was he's a 28-year-old male. He presented initially with symptoms of encephalitis and got stabilized. But something caught the attention of the neurologist. It was hypertension, which was uncommon in encephalitis presentation. Usually there is tachycardia and hypotension. So they were wondering why this is so. So a detailed history was taken, which revealed that his elder brother had died due to similar symptoms on May 5th at Government Medical College, Kozhikode, where I work. At that time, I was in Malappuram. And at the time of his admission, his father and aunt also started showing similar symptoms. So if you've seen the movie, not web series, in Netflix documentary, Curry and Cyanide, the first suspicion would be of intentional poisoning. But this neurologist had worked in Malaysia earlier, and he had read about similar presentations of encephalitis, and Malaysia had documented Nipah in detail. Even they even had guidelines. So what they proposed to do is, based on his suspicion, they send the samples to Manipal Institute of Virology, and at that time, thankfully, Manipal Institute had a project in collaboration with CDC for multiplex viral panel testing, in which Nipah also was there. So Manipal consented, and the samples of this person was sent with the bystander to Manipal. So So on 19th, we got the result. But the protocol is that only after NIV does the confirmation, we can declare it as an outbreak. So it took one more day, and on 20th May 2018, this was declared to be Nipah outbreak. But the tragedy is that it had claimed 17 lives out of the 19 affected by the time the confirmation was out, with a case CFR of 89.4%, which is a devastating outbreak in Kerala. So all the systems started functioning after these deaths happened, And then we were looking forward to more deaths. Oh my God, what's going to happen the next? We were unaware. So we had to work. We didn't have any regional guidelines. We didn't know how to go about it. We had to set up systems for lab confirmation. We had to set up a protocol for contact tracing. So there was a lot to do at that point of time, and that made it really dreadful. So if you look at this, in the 2018 outbreak, ICMR came up with plotted something like this, having consolidated all the cases. And from the date of onset, this is the primary case. And look at this, there is a clustering of cases in and around here over a period of a week. And then you can also appreciate the secondary cases that has happened later. Now, in Calicut Medical College, my colleagues tried to depict the transmission dynamics by dividing the cases from the primary case. These were the cases who got the disease. So they divided the primary, the cases into family cluster and hospital clusters. So this primary case was admitted in different points. Of course, he had contact with his family. Then he was admitted in one of the hospitals in his hometown. Then he came to Calicut Medical College. And so there were different clusters they could identify. So that was one other way of looking into it. And ICMR also came out with a good infographic, which showed the points of contact in the hospital where a person-to-person transmission from primary case happened. See here, this was the first case which went undetected in our hospital. That is the primary case. So what is the definition of primary case? That's important. Primary case is the first case of a disease that happens in the community. And what is the index case? Index case was his brother who came to the attention of the physician. So that's important to know. So this is the primary case who went undetected, and he infected around 8 cases, 1, 2, 3, 4, 5, 7 cases in his hospital, hometown. Then he was referred to medical college here. In the casualty, he again infected 5 persons. And then he was wheeled to the CT scan waiting room. There he infected more persons. So others were secondary cases. So this is how, in hospitals with lax infection control protocols, there is ample chances of Nipah spreading like wildfire. So a simple masking and hand sanitization and personal precautions can prevent or halt hospital transmissions. That's a message which we need to always think about. Now, what we did was, by consolidating all those, the cases and doing an investigation, we came out with these findings. The mean incubation period of the Nipah outbreak 2018 was 9.3 days. Predominantly male because they were engaged in outdoor activities, predominantly in the productive age group, 41 years. And the 75 years were victims because they were secondary cases, high case fatality rate, and the reproduction number was calculated it was less than 1 throughout the outbreak. And when the outbreak started declining, it was about 0.48, which shows that outbreak can be halted. And that is an important point to remember. Though it is a highly lethal disease, the victim or the patient is infectious only towards the later part of the illness. And that is why hospital contacts seem to be much more than the community contacts. And as I've already told, that primary case is the first case which happened in the community and which went undetected. And the index case was his brother, who was brought to the casualty. And the last case expired on May 31. One thing which we all got exposed to was the case definitions of Nipah, because that was important for us, because the patients and suspect cases from the locality of this Changaroth village and around were brought to our casualty they were flocking to our casualty. So we had to do a screening for these patients, and we had to know the case definitions in detail. So the case definitions are suspect and probable cases of Nipah. Suspect cases would be person from that area, from any person from that locality who presented with AES-like symptoms or acute encephalitic symptoms, or it could be ARDS symptoms also, acute respiratory distress symptoms. Probable case would be a person who resided in the same village or who had contact with the person who died. Now, how do you confirm Nipah? If such a person comes to our casualty, we do a screening. We try to do an epidemiological linkage by categorizing the person into either suspect or probable. And once, if it is thought to be, and we take uh, samples for testing. We take throat swab, urine, serum for testing in our point of care, casualty, red area. There is a cubicle where we can isolate them. And so for confirmation, we have TrueNat test in our microbiology lab. So after doing the initial TrueNat test, if it is thought to be Nipah, then we start isolating the case. So this is how the case definitions help us. And this is the Department of Health and Family Welfare has come out with a module, which is a good read on the guidelines on surveillance and diagnosis. Even the Ministry of Health and Family Welfare has a wonderful publication on Nipah virus infection. So by doing all that, we could contain the outbreak by June 10, 2018, twice the incubation period. So as I said earlier, the incubation period could go extend till 21. So double the incubation period, we took it as 42 days from the first case. So what was role of community medicine in all this? Well, at that point of time in 2018, the health system, they were not really none of us were experienced with contact tracing because we've never had, we've done something like this. So the Department of Community Medicine in Kozhikode and Malappuram were given the role of charge of doing the contact tracing. So in Calicut, we could identify 2,000 contacts, and in Malappuram, 239 contacts. How did we do that? So for that, in Malappuram, we needed to have some guidelines for contact tracing. So that night, I remember when I came back, I started doing some literature search, Googled up, and chanced upon this document where WHO had a contact tracing guidelines for Ebola virus, which is highly lethal and similar to NIV, Nipah virus. So they had given clear categorizing of contact definition. So this is what we've used. So any person who have been exposed to a Nipah case, who had slept in the same house, who had direct physical contact, or had participated, not just participated in the funeral, but should have direct physical contact with the deceased, or having participated in burial preparation, having bathed the corpse, had touched the blood or body fluids, had touched the clothes or linens, a baby who has been breastfed by the case without adequate personal precautions. We categorized all of them into high-risk contacts, and the others were no risk. So that is how we could limit the number of contacts, or else it would have been explosive. And because any Tom, Dick, and Harry who were around will be identified as contacts, and it's going to be really tough because you have to follow them up for the symptoms for almost 21 days from then. And all the information needs to be listed, and it is going to be a humongous process. So you need to do judicious contact tracing and risk categorization. So these were the forms which helped us. Of course, it was the contact tracing was not easy at all. The first thing was during the 2018 outbreak, all of our faculty were quite apprehensive because we had to go to the field then. Later on, we started doing telephonic contact tracing. Going to the field meant we had to be clear about what all personal precautions we had to use because all of us had families and we had to go back also. Should we get isolated was the question. But then we read the Ebola protocol and found out that if you use N95 mask, a good gown, and follow social distancing, then that's fine. And none of the family members were infected by that time, but we could interview them. And we had to, so that is how we did it. Daily reporting was done and psychosocial counseling to families. So daily reporting was done to the district health system through email, and we also they had shared with us a Google form. Now, other parallel activities were going on. And that activity was we had to prove that the team had to prove that indeed the source of infection was from bats as reported in Malaysia and other places. So the government had to take the help of animal husbandry, forest departments, and NIV ICMR scientists. They did bat studies and found out that in and around that place, bat positivity was 19.2%, which was an indirect indication, yes, if the bats were infected and the spillover could have happened. Of course, there were interesting conspiracy theories like, the primary case had gone to Malaysia and he was an agent of Malaysia and he was a spy and all that stuff. And his mobile was confiscated by the police, but nothing could be proved. He was such an animal lover. And his story, you can actually watch in the movie Virus, which is a Malayalam movie, which is there in Amazon Prime. And that will show how good an animal lover he was. And the next important thing was at that time, we never had any drugs. So, and people were dying like flies. So the literature stated that ribavirin could be used, monoclonal antibodies were there, and favipiravir were there. In the current outbreaks, one more drug has found place, and that is remdesivir. And we have been using remdesivir, and we were able to save a number of contacts by this drug. So it really works, and that is really something which gives us a lot of hope. The thing is, though the government could procure monoclonal antibodies from Australia on compassionate grounds, it was in an experimental stage. We didn't use it. But now something this is hopeful because the government of India is also doing a trial. I mean, they've collected serum of survivors and they are trying to develop monoclonal antibodies from the survivors. The next challenge was cremating the victims because being highly infectious, nobody was willing to cremate and nobody knew actually how it could be done. Again, the Ebola protocol came to help. And this is a corporation medical officer who took charge and even did prayers for the victims. And he trained his whole force, all his health personnel to conduct this burial. And this is what was done, the Ebola protocol. 10 feet pit was dug, 5 kg bleaching powder was spread, body was packed in airtight plastic double body bag and lowered. Now remember, this is the same thing they did for the COVID victims. So Kerala had done this earlier than COVID. So we were prepared with all these protocols, and that is why we could do rapid response in COVID. Now, this is what we did in a nutshell. But then again, we
Asma, you have been muted.
Oh,
Asma,
sorry.
yeah.
Am I okay now?
Yeah, now it's okay.
Yeah. So in 2019, we have another attack in Ernakulam in 21-year-old male. They did 330 contacts were traced because all the guidelines were in place. The health system was ready. Highlight of this outbreak was that. But again, the source of infection could not be proved conclusively. Cut to, oh, sorry, Animesh, Something got paused, I think.
No, I can see 2019.
No, 1 sec. I think, shall I I can't see the screen.
Okay. You
Let
can
me try.
exit and reshare from there.
Yes.
Yeah, you've exited.
Can you see the screen now?
I can.
You can.
Yes.
Fine, fine.
2019.
Yes.
Yeah.
So again, in September 2023, we had another outbreak. A 12-year-old boy succumbed to death in 2021 in Kozhikode. Again, we did a contact tracing, 240 high and low risk contacts. Bad studies done, showed presence of NIV antibodies, but antigens could not be detected in the bats. Mode of spillover, inconclusive. The assumption was that the boy had eaten some fruit. The fruits were taken for sampling, but no virus could be detected. But one important thing is that no secondary cases of other cases were there because we were masked, and even in the hospital we had followed good personal precautions, and that was something. This happened during the second wave of the COVID pandemic, and the outbreak halted with a single case. And in September 2023, 2 years later, we got another one from the same area. That is something really, really important. Within 15 kilometers or 50 kilometers from the same area, same geographical belt, these cases started coming up. Index case was a 9-year-old child in a private hospital. And later, some of the family members also started showing symptoms. And his father had died earlier in one of the other private hospitals, undetected, no tests were done. Thankfully, his serum samples were there in the isolate refrigerator. And later, retrospectively, he was also diagnosed to have Nipah. So here, the primary case was the father. And what was starkly different was earlier, most of the cases had encephalitic presentation, but here respiratory distress was the presentation. And male gender and mean incubation period of 9 days, and location had from the same geographical belt. Then last in July 2024 and September 2024, the disease shifted to the neighboring district of Malappuram. 2 cases. One was in a 14-year-old boy, and other one was in a 24-year-old male who was a student in Bangalore. But both of them had come to this place, and both of them gave. It is reported that they had consumed fruits, but inconclusive again. So by comparing all these outbreaks from 18 to 24 in India, we came to certain conclusions that the disease had predominantly male preponderance, productive age groups were there, 3 outbreaks had geographical commonality. All these outbreaks were in areas adjacent to natural forest cover. Earlier, the outbreaks used to happen during summer season of April to May. It was hot and humid, and the fruits ripen at that point of time. But then now what we see is even if in September, October, we are having outbreaks. So spillover throughout the year is documented. And all primary cases have the reported consumption or handling of fruits, but not proven. Now, what we did is we also mapped the bat population. It was not we who did it. It was experts from NIV in 2018, 19, 21, 23, 24. They studied, they did zero survey of bats in that area. And almost all the years, they found out that these bats had antibodies to NIV, to the Nipah virus. And genomic sequencing, of course, that was also done. And in 2018, we found out that the strain that is circulating in Kerala had genomic similarity to nucleotide similarity to the Bangladesh strain. And almost all these 2021, 23 outbreaks were similar to the strain in 2018, except the 2019 outbreak strain, which was a little bit of mutation for that strain. So in recovery and response, what worked? The important strategies that have worked in Kerala have been triaging of cases into low risk, high risk, and epidemiological screening, linkage right from inception of the patient in the casualty, isolation of cases, contact tracing, good risk stratification, and continued surveillance. So we are right now, even now in our casualty, all the AES and ARDS cases are put under surveillance. TrueNAT test or multi-viral panel test is being done for that, for these cases, so that we don't even miss one case. And brisk state response have to be remembered thanks to all our health ministers, including the current present health minister, Srimati Veena George. All the teams landed at Kozhikode, and they give us support, even experts from AIMS, NCDC, Pune, ICMR. And that is why you see a lot of publications on Nipah. District collectors, yes, they led our team, and every evening we had to report to their chamber and update them regarding the contact tracing. And that was a cumbersome exercise. Challenges in infrastructure, yes, because we did not have special wards, we did not have ventilators, staff, and infection control protocols for handling Nipah patients. But everything was put ready, and immediate training was given to all our staff, including ambulance drivers, with public-private partnership. Infection control protocols were put in place. But what happened? As people came to know that in the hometown of the first case in 2018, the hospital got empty. In our college, the hospital was empty because there was a lot of panic and misconceptions among patients and the other community regarding Nipah at that point of time. Now they are a little bit more confident. So we had to do door-to-door awareness programs, and the collectors also said they had to instructed for social distancing during Ramadan and religious festival restrictions. Since there was a lot of ostracism from the community, food kits had to be distributed to the affected families, and treatment expenses have also to be bared. And one thing that stood out is that from community medicine during contact tracing, we also gave psychosocial counseling to the families because they got close to us. We used to follow them through telephone for the coming 21 days, and all the health concerns were also addressed. So that was something which was really worthwhile for us, and we felt so glad that we could make a change or difference to those people's life, because they were like, every other day they were so frightened as to whether I'm going to be the next victim. So this is in a nutshell how we have tried approaching this disease in prevention and containment, but still a lot of puzzles need to be solved, including finding out the source of infection for the primary case, proving the mechanism of spillover from reservoir bats, identifying other intermediate hosts in our community, and demonstration of agent in the fruit samples. So, but we did learn some lessons, and the lessons are, if there is a slip in the infection control policy in the hospital, that is a warning sign. And all the important points of contact, the workers should follow personal precautions. So in order to to prevent the next outbreak, are we able to prevent the next outbreak? I'm not sure, because the reservoir is there and the human behavior is yet to be ascertained. So I think from a community perspective, two important things need to be driven to them. One is regarding their domestic pets, like maybe cows, buffaloes, or cats and dogs, and do not leave them under the fruiting trees where the bats roost or bats approach, because that may be one reason. So we are trying to focus that message to them, to disseminate this message. And the second thing is, do not eat fallen fruits, have hand hygiene, etc., etc. And from the hospital part, because many of the deaths have been hospital clusters in the initial outbreak, preparedness is important, early detection is important, and currently we are having an ICMR project in our college on event-based surveillance mechanism. All cases of fever and other infectious diseases reporting to our hospital, they try to identify signals or clusters from the hospital and community, and we constantly follow this up. Also, we have improved surveillance of AES and ARDS cases. Point of care tests have been strengthened. Infection prevention control practices, although we try to do it at times, of course, there are going to be gaps, but ultimately it is a One Health approach that is going to work wonders in this. Establishing a BSL-3 lab, it is under construction in our hospital. Until then, it is a mobile lab from NIV Pune, which comes here to do the test right at our doorstep. Standard treatment protocols have been developed, and remdesivir is currently the antiviral agent that is used. And now currently monoclonal antibody research is going on to develop indigenous monoclonal antibodies. Climate change studies are being done, and also disease modeling studies. Some of the researchers have taken this up. These are some of the snippets from the field which we did. Like, this is the controls cell where our postgraduates are posted for contact tracing, telephonic, and our DME has accompanied us to the field of the patient victims. These are the places. This is where the bats roost, and this is the arachnid cycas tree where the bats frequent. We even checked CCTV footages from the hospital to document person-to-person transmission and behavior, as well as whether the personal precautions are in place. So these are some of the, and we have also done a publication. A number of publications have come out from the other team members also. This is one of the recent publications where we have done to share our findings on recurrent Nipah outbreaks. Now, coming to the WHO, I've said that it has prioritized Nipah for prevention control in alignment with the Delhi Declaration 2019 on emergency preparedness. Why is it important? Because the WHO has prioritized countries into two, category A and B, member states. So India and Bangladesh are countries where human infections are reported, but in Southeast Asia, there are countries where imminent Nipah outbreaks might happen. So they have to take care. So whatever said and done, I think we can't be in a silo. We have to work together, because right from forest department to animal husbandry to various departments have to play a role and One Health in coordinating, communicating, and collaborating, not only to address a Nipah outbreak once it has happened, but in order to prevent the outbreak also, we need to have a common portal where all these events are reported, and each agency can happen what is happening. If there is increased deaths of pigs in the forest, then probably the bats, forest departments also have bat counts, and the travel paths and roosting sites. And then we, from the health system, we tried to map the cases of AES, do testing and surveillance, and we try to link all these together, especially in the summer months, hot, humid months. If we strengthen the surveillance, then this disease we may be able to control this disease. We cannot eliminate this disease or eradicate the disease because bats are still the reservoirs. And we also need to find out who the intermediate host in our context is. So with that, thanks a lot. Thank you for the kind listening. Shall I stop sharing my presentation?
Yes, Asma, it's done.
Yes.
Okay. Am I audible?
Yeah, you are.
Yeah. So I was following my routine of walk, so that's why I'm
okay.
Yeah. So I'm just waiting if there are any questions in the chat. As of now, nothing. I saw that one comment is a very informative presentation. Okay, so Ms. Komal Tawar is saying, I want to ask from where we get the real data of Nipah. That's a question.
Well, that's a question. Real data of Nipah is with the district health system, and I don't think they will share it with you. It's difficult even for us to get the data.
Okay.
Yeah.
So any other questions, any other things? Anyone else wants to share something? Anybody wants to ask, okay, actually, I'm working on disease modeling, so please let me know if possible. Can you
Yeah,
cover?
that can be, what you can do in modeling is that there are a number of publications on Nipah, and the recent publication that has come out is, from one of our colleagues who's working as a nodal officer for One Health. So I can actually share his contact number with Animesh. If you can help them out, I can give the contact
All
number,
right.
and you may
All
talk
right.
with him. Yes.
Yes. So you may reach out to us.
Because disease modeling requires a number of variables, like from the climate, but that's all available from some of them are available from the public domain itself. Humidity, temperature in these sites, disease counts, but what is happening is, IDSP data, that is integrated disease surveillance data, is required. And maybe even if you go to the IDSP portal, you may not get the factual correct data. So for that, you might have to approach the district health system, the counts, to get the counts.
So there is one more question which has come.
Yes.
So ma'am, I have a doubt as how to select fruits from shop, and should we have to take any precautions
Yes.
before eating? I think this
Yeah,
would be a
that's
common question. Yeah, you would
yes,
be addressing.
that's a really wonderful question, because I just
Yes.
forgot to mention. Currently,
Yes.
what the IEC messages which we are propagating is that, especially in this area, wash the fruits properly before eating. Wash your fruits. Earlier, we used to say that it is OCD, obsessive compulsive disorder, but then all of us follow that. We wash the fruits either in vinegar solution or with soap and water, wash the hands, and then have peel the outer peel of the fruits for those fruits and have it.
Yes, and we also do one more thing here at
Yes.
home. We also try to soak these fruits for some time.
Yes.
If
Yes.
nothing else is available, then what we do is we put some salt and water,
Yes.
and it's
Yes.
soaked for at least 15, 20 minutes to 30
Yeah.
minutes. And
Yeah.
then we take it out and wash it again thoroughly. As you said, we
Exactly.
wash it, put it in that, and then, so at least some way it probably will
I
help.
know. But then you know what happens? So this is a message which is to be disseminated to the public, to those communities where which lies in the Nipah belt. So, but to what extent this is accepted, I don't know. Because kids, especially young boys, they go to the forest and climb up trees and have fruits. In the last case, a 14-year-old boy reported that from Malappuram. So they
Okay,
go for short picnics. So, from schools also you need to give them awareness.
right. Any other question from anyone else? Or if somebody wants to say something, you can put it in the chat and we will try and give it to you. Okay, so bitten
Yeah, there is a
fruits.
question there.
Yeah.
Ma'am,
Is
bitten fruits are the only
yeah,
reason, right? Something like
yes.
that? No,
Yeah, so they are
see,
asking, is it only the
yeah,
bitten fruits?
yeah. So that's what I presented. It is inconclusive. Because
Okay.
if you have to prove that bitten fruits are indeed the reason, then you have to have viral antigen from the fruits. That we have not been able to do. So
Right.
it is still a hypothesis. Only
Okay.
thing is there's a commonality that all these victims have had fruits. Now, if you ask myself and Animesh whether you had fruits, we will also say yesterday we had fruits.
Oh yes. Why yesterday? Today I had fruits.
Exactly.
Afternoon I had. Morning I had.
Exactly.
I'm fond of fruits. Yes. And one more question, Asma.
Yeah.
If accidentally we come in contact with bats, what to do?
Accidentally come in contact with bats, all you need to be careful is that don't go into caves where there are aerosols. But otherwise, bats are around. And also, even this is a question that is concerning to me because my home is surrounded by bats. There are a lot of trees around, fruiting trees, and bats are there. And bats used to, frequent around our houses, and also we see excreta, bat excreta on my car, on my wall. So what we did is that we didn't cut down the trees, but what we did was we put a net around that place so it diverts
Yes.
its path and go. So maybe that can be done. But this accidental coming in contact, unless if you feel that the bat's urine or excreta have been inhaled or it has fallen into your eye or mouth, in that case, maybe you can have some sort of, let's say, medical advice or so. But otherwise, you know, don't have to worry. Only thing is, don't try to frequent to caves where, you know, those dark jungle caves where the bats are there. That we can't guarantee. And don't eat bat-bitten fruits also.
Right.
Other questions
Any
are,
other questions? Let me just check.
yes, it is there, I think.
There is, yeah, there is. Is recovery possible in case of Nipah? And if yes, is there a reinfection possibility?
There is a few more other questions earlier, I think.
Yeah, there is something about there is
Any particular
any
reason?
particular reason for recurrent Nipah outbreaks in Kerala and not in other states? Is it due to the surveillance? So
One
partly
is
maybe yes,
that
but
the
you are the best
bats,
person.
yes,
Yeah.
bats in Kerala, I have said that there is zero positivity of the bats. And Kerala being an overcrowded state, the human animal contact is more. And the distinction between urban and forest and rural, it is totally gone. So it's all, you know, we are trying to frequent the forest every day, and deforestation is being done. So that may be one reason when compared to other states where there are vast farmlands, there are trees, where the forest can roost. That is not there. Here in Kerala, everywhere there is human contact. Wherever it's a small place, that could be one reason. The second reason is that we're able to detect the AES cases because the surveillance is strong, and maybe that is why, as you rightly said. Yes.
Any hopes for Nipah vaccine in the Nipah belt? Dr. Akila is asked.
Nipah vaccine is they are trying to develop a Nipah vaccine, but it's not there as of now. Maybe
Okay.
it will be there in the future.
And there's another question. Is recovery possible in case of Nipah? And if yes, is there is a possibility of a reinfection?
Yeah. So from our experience, some of the cases who showed symptoms were given remdesivir and ribavirin, and they indeed, a few of them survived. But we have one case who's a healthcare worker in the 2023 outbreak who survived after being put on remdesivir, who had mild symptoms of Nipah, but now he has had a reactivation or relapse. So he's having encephalitis and he's in a comatose state. So it does happen. Relapse may occur for the survivors.
Okay.
And
there
with
is
encephalitic presentation.
okay. And there is another question which has been put up by KS.
Yeah.
Any programs implemented for Nipah surveillance, especially in the endemic areas?
One program is in our medical college. We have an event-based surveillance project that is run by the ICMR, where all the cases that is coming to our hospitals will be mapped and signals will be sent to the ICMR headquarters, and clustering will be identified, and that will be disseminated to the district health system. But there is a danger here. 3 cases of fever, you better be. And another thing, what is happening in our hospital is that, and even there is a cluster of hospitals in and around us who are working together. So if there are any cases of AES, especially in our hospital in ARDS, we immediately do the TrueNAT test and try to see if it fits Nipah. That's the first test which we do. So that gives us a clue. So this is what we are doing.
Okay. There's one more question from Dr. Akila. What would be the hotspot and how many kilometers should we avoid when a Nipah case occurs or is notified? A very interesting question.
Normally, what the government does is in and around the case, around 5 to 10 kilometers, we try to keep it as a hotspot or zone. But then sometimes, stringent measures like cordoning and those are done, which the WHO says is not required. But at that point, if what happens is, if you think logically, Nipah is not a community, it doesn't spread through aerosol also like COVID. It is even less infectious than COVID if you look at it. So if a Nipah case happens in a household, only that household need to be isolated or the persons in that household need to be quarantined. And WHO again says it is household home quarantine and looking out for checking for symptoms using ASHA workers or healthcare workers is all that is required. Okay. So yeah, because the person is infectious only towards a later phase of the disease by the time he would have gone to the hospital. So then the onus is on the contact tracing team to find out the contacts of this person and put them under surveillance.
So there is one
Now,
more question from.
Yeah. So all these cordoning and geographical mapping and all those stuff like identifying hotspots, etc., is for the ease of controlling and containing the disease as well as a political strategy. That something has to be done there, right? To prevent,
Right.
yeah, movement from this place to that place and the contacts moving out. So that's why we do.
Right. So Dr. Rajat Rao is interested in knowing if there is any seroprotection offered by the recurrent infection. Like in some diseases, there will be a seroprotection. And if so, how long does it last?
Well, I think that sero survey, only those sero survey and studies by ICMR and NIV will answer that question. What has been done by Dr. Pragya Yadav in 2023 was that she was able to identify subclinical infections in 3 contacts. But for how long, I'm not sure. At that point of time, serial measurement has to be done, and it has not been done till now.
Okay. Thank you. And there is one more question about, is there any transmission from bats to bats? Because it is not possible that all the bats are having Nipah.
That's true. As you've rightly, we noted that only around 29% bats may be infected. Bat-to-bat transmission is there? Is there any transmission from bats to bats? Well, that question, I need to really look into that. I've not really thought of that inter-bat transmission. Maybe I can answer it later. I can send the queries to, because it's basically
Sure. So you can get in touch. I've put my number already.
I can make sure. I will send that question. Please note down that question. Animesh.
Right. I'll do that. So I think that's all we have. Thank you so much, Asma. It's been a pleasure to have you. And there is one more. Okay. So people are thanking you and they're happy with the session. So yeah, it's been appreciated. So thank you so much, Asma. And it's been a pleasure to have you here. And I'm sure that the audience which has been online, they have been benefited. To inform all of you, this will be actually put up on the YouTube channel of IAPSM Karnataka in about 3-4 days from now. So we always do that, and all our previous webinars are also archived there. So it's available for any of you to refer to, or you can even give it to the other people that you have connect with, and then you feel that they might be benefited. So with that, let me thank IAPSM Karnataka chapter as well as Clarnet, and also thank my colleagues in the office of IAPSM Karnataka as well as all the audience. And thank you, Asma. Thank you very much.
Thank you. Thank you.
So with that, I would sign off. This is your host, Dr. Animesh Jain. And I'm also a professor of community medicine at KMC Mangalore, and currently also hold the office of Vice President, IAPSM Karnataka chapter. Thank you. Over to you, Clarnet team. Srishti.
Thank you so much for extending us the opportunity to host the session, and I hope you all had a seamless experience. So with your due permission, I'm closing the session today and looking forward to hosting you again. Thank you so much.
Sure. Thank you so much.
Thank you.